Good morning, everyone. It's really an honor to introduce Dr. Patrick O'Gara to cardiovascular ground rounds here at BIDMC. Dr. O'Gara is the Watkins Family Endowed Chair in Cardiology at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. He received his undergrad degree from Yale, where he was also a college baseball player, played every position except for first base, right? That's what. And then went on to complete medical school at Northwestern University. He then came back to the East Coast for internal medicine and cardiology training at Massachusetts General Hospital. And he was subsequently appointed a guest researcher at the NHLBI, and following this joined the MGH faculty, where he would eventually meet a young, intrepid Argentinian cardiologist by the name of Robert Gersten. They go back 35 years, 30 years, yeah. And then importantly, over this period, Dr. O'Gara and his wife had 3 children, one of whom, Brian O'Gara, is a beloved anesthesiologist here at BIDMC who works with many folks in the cardiology division. Dr. O'Gara eventually transitioned to the Brigham and Women's Hospital in 1995, where he served as interim chief. He served many leadership roles for the American College of Cardiology and AHA, including as the ACC president in 2014-2015, the chair of the ACC-AHA Joint Committee on Clinical Practice Guidelines. He's also received numerous awards, including the Council's Distinguished Achievement Award, the Laennec Master Clinician Award, the Laennec Clinician Educator Award, and the James Herrick Award. And on top of that, he's participated, as we all know, as writing committee chair or member for several practice guidelines and expert consensus documents, and is also currently the deputy editor at JAMA Cardiology. I'll just add, and it really goes without saying, that Dr. O'Gara is an internationally renowned master clinician, educator, and investigator. But perhaps most importantly, he really is a role model and exemplar to many of us in the cardiovascular community. Because he is the consummate gentleman. We talk about this a lot at the Smith Center, actually. Incredibly kind, generous, exceptional mentor, especially to young faculty and trainees. And so I know many of us in the division, including myself, and my wife now, have benefited deeply from Pat's teaching and mentorship. It's like a family thing. And so it really is a pleasure to welcome you to Grand Rounds here, Dr. O'Gara. Thank you.
Thanks very much, Richie, for those very kind remarks. And it's really great to be back here at the Beth Israel. I think the last time I was here was with Dr. Josephson and with Dr. Popma, who was still an active member of the faculty. And it's a great place. You even have this beautiful view. I can certainly tell you it trumps the view from my window. It's always a bit challenging, isn't it, to give grand rounds to your home institution or to the institution across the street. I think without question, the more challenging talks given over the course of the last several decades have been either to, as Mark Pfeffer likes to say, the home team, or to your former place of training, or to a place where you know a lot of people. But I'm going to sort of switch the entire paradigm and say, you know who I am and you know who I'm not. And so you get what you get, so to speak. And I hope not to disappoint. Now, I thought certainly my buddy, Dr. Bono, was here recently, and I'm sure they talked about 50 years of aortic stenosis or something close to that. So I'm going to talk about 51 years of aortic stenosis. No. All right. It's a special treat to have my son Brian here, who, when not attending in the critical care areas here, is playing golf or thinking about playing golf. So it's nice that he could take time out of his golf schedule to join us. Now, this may violate first principles about whether there's a camera here and you're transmitting to Leahy or someplace like that. But I'm going to walk around and call on the audience as we go through the talk. And hopefully we'll have plenty of time left over for questions. So can you hear me here all right? So this is kind of more of a contemplative discussion about, I think I can take the freedom of saying this, about sort of sharing with you where I am as somebody who, as I think Rob said last night, you're on the back nine, I'm in the clubhouse. And sort of what inspires me today, what might inspire me in the future. And are there any fellows here? Or it's great, you got free food here. How can you not be here? Sitting in the zip code behind us. Okay. So I guess we have lost that. Okay, so I'm going to stand here after all. No, this isn't advancing either. There we go. All right. Yeah, that's all right. So I have no disclosures related to this talk, but I thought I would start with this. This is, of course, the time and space continuum. This is something that we live in every day, right? So imagine yourself as a medical student and as a resident and then as a fellow at the bottom of the funnel. And you're trying to grasp information about all things at all times so that you can make this transition from being a trainee to being somebody who can take care of a patient at the bedside or write a grant or some combination of that. Then you become specialized, don't you? Especially if you're in an academic environment, because lack of specialization will leave you being a general cardiologist like myself. Nobody wants to be a general cardiologist, right? And then you come out the other end and you sort of come to this realization that time is really short. In fact, time gets faster as you get older, or at least it seems to get faster as you get older. What do you really want to do? What really is your passion? And how is it that you can get there, whether it's in medicine or whether it's something else? Maybe you want to be a math teacher, or you want to teach coach Little League Baseball, or some combination of that. So this is, I can't do it.
Unfortunately, there's a Zoom microphone.
So this isn't working. All right. So yeah, there is a lot of things. Okay, can you hear me now? All right. So Ozzy Boyd to everyone, is anyone's audio off? Okay, I hope so. So this, if you're like me, this is how you start every day, right? You start this balancing act because you're being overloaded with information. You wish to turn off the radio on your way to work, right? Who wants to listen to the radio these days? No one really wants to listen to the radio. Then you log on and you get 58 spam emails about some conference in Padua on the ribosomal RNA or some combination of that. And it's very hard to keep your balance, isn't it? It's very hard to feel like you can catch up, let alone stay up. And it's very difficult to maintain the filter that you need in order to get through your day and understand what's important, what's less important, what can I leave behind. So a lot of people have asked me over time, and we have a lot of mentoring sessions now, and I'm sure you do too, about a career path, especially among the fellows and those who've transitioned to junior faculty status, early career individuals, mid-career individuals, and don't forget, those of us who are at late career. This trajectory doesn't stop. If it does stop, then it's time to hang up your cleats. So this is what people think about when they are total strangers to myself or somebody like Rob, right? Or somebody like Bob Bono. I mean, it just must have happened, right? You were hatched out of medical school. You knew immediately you wanted to be a cardiologist. You know, Bob kept those notes. And I don't know, did he show you that picture where this note? Yeah, okay. And then of course, he's going to be a world expert in aortic stenosis, among other things, right? Didn't happen that way. Of course it doesn't, all right? This is how it happens, right? So you have an idea, you try to test it, you fail, you pick yourself up, you have another idea, you talk to people, you sharpen the questions that you're asking, you search for the resources that you need in order to answer the questions, and then you ask additional questions based on the small insights that you achieve as you go. They accumulate over time, and your career starts to take a certain direction. And if anybody thinks it's not like this on the right, just wait, just wait. So there are a few things that you're going to need in order to maintain your equilibrium as you go through a career path that looks more like the one on the right than the one on the left. So this is a talk about a general cardiologist. What's a general cardiologist at an academic medical center? It's called a utility infielder. Or is anybody familiar with that kind of moniker? A utility? Can you think of a utility infielder who made it to the Hall of Fame in baseball? Can you think of one person? Who's the last utility infielder you can name? Who? Okay. And so the follow-up question is, who's he? There you go, right? Okay, maybe somebody like Brock Holt. Remember that name? Right, nice. Everybody liked the guy. He could produce at various times, but he played this, he played that, and then, of course, he's left off the team, right? Because there's an 18-year-old from the Dominican Republic who's the next best thing, right? That's life. That's life. So I think the general cardiologist in the 21st century at an academic medical center is certainly not quite a jack of all trades, is she or he, right? And certainly a master of any one specific trade. So, for example, we want you to put this patient on the thoracic surgery service with atrial fibrillation. Kind of a common problem, right? Atrial fibrillation, irregular heart rhythm, something like that. Do you think we need to call an electrophysiologist? What do you think, right? Must be a really special case. Or we need somebody who's cognizant of advanced heart failure as compared to heart failure. That's sort of like being your plane that is completely full as compared to full, right? Like, all right, what's the difference? So where do you fit in when your patients are increasingly sophisticated and talk to you in terms of like, what are your limits? And that's a reasonable thing to ask anybody in this particular era of super specialization, especially when there's way too much to know, right? And it does help that there are experts in various areas because our patients actually require that. But if you don't have a little bit of resilience, it's going to eventually play on your self-image. And that's not a good thing if you need to see a lot of patients over time. And keep your energy going. So where are you going to fit in? There are plenty of places to fit in, but I think we're well past the stage at which one needs to bemoan the fact that you're not super specialized at various stages. And for those who are super specialized, fabulous. We can help each other. So what do I need in the 21st century to survive as a general cardiologist? What do I need? I need to understand some things. I need to understand things about genes and wearable devices, although they certainly haven't been scaled up to any useful degree, at least in my practice. Imaging, of course, imaging is the currency of the realm, isn't it? Everything is imaging. It really shocked me. Last week, I was asked to give a talk to the residents on aortic stenosis, kind of a common problem, right? It's like blocking and tackling. It's like going to an Ohio State football game. Aortic stenosis, So we started to talk about the carotid contour. I said, it's a reasonable thing. Like, how do you recognize aortic stenosis? And at the bedside, how can you assess whether or not it's advanced? And one very smart person from the back of the room said, why would I ever want to feel the carotids when I can do an echo? It's speechless. Like, what can you say, right? That's where we are, right? I can carry a little POCUS machine around and beat you on your physical examination every time. This is a new era. Okay. Well, it's a little bit off-putting, I have to say. It's like, well, so like, this is what I do. Anyway. Imaging is certainly the currency of the realm. And then if we're not a little bit familiar with artificial intelligence and what's under the hood, we could really get boondoggled, I think, in the process. So this, of course, will lead to our ability to predict incident disease, I believe, maybe, and help with diagnosis, treatment, and prevention, won't it? And everybody is rushing, I think, to try to put this into an integrated schema that will allow us to get better at what we do and hopefully improve the care of our patients and their outcomes in the process. But, here's where somebody with limited translational or statistical or epidemiologic training can get stuck in the weeds if not careful or not having mentors or navigators to help him or her. So here are some tools that I think are required. Maybe a little bit of knowledge about genetics, systems biology makes a lot of sense, at least from a 35,000-foot level, but don't ask me to draw those nodes and edges, right? Okay, maybe I don't need to know all of that, but I think I need to be conversant in this. Artificial intelligence, I've already mentioned. Statistics, I'm here with Bobby, of course. And it takes quite a bit, I think, to pull yourself up to some level of competence when trying to understand whether the paper you're reading actually is true, whether the observations are valid, whether they have been tested appropriately, and in many instances, whether they've been externally validated. And then trial and study design. Gosh, doesn't Mendelian randomization make the hair on the back of your head stand up, right? What's Mendelian randomization to a general cardiologist? It sounds like a biology experiment. And maybe it is a biology experiment, but it's been a few years now since Sam Gidding, who is an AHA volunteer, made a plea in front of the Joint Committee that Mendelian randomization studies should be included in the evidence base by which recommendations are made. And there may be a few instances in which that would pertain, maybe 1 out of 100, but that, of course, required everybody who doesn't know anything about Mendelian randomization to try to come up to speed and answer a question of that nature. And it's, I think, a very sort of facile thing that has descended upon us, and the literature is replete with these kinds of studies. And then there's, of course, double randomization and all other sorts of things that come into focus or out of focus if you're not up to date with it. And then let's not forget, of course, the most important role of mentoring and role modeling in terms of helping you navigate that high wire act I showed you before. I might need the things on the top, but if I don't have the things on the bottom, I'm stuck. And I think that what I'm trying to say, especially to the young people, is have the courage to let people know what you don't know and what it is that you need. The faculty at a place like Beth Israel are more than honored that you would ask them how to navigate the next step. But sometimes it takes a certain degree of self-confidence to admit what it is that you don't know or the tools that you don't have. Rest assured, we weren't born knowing how to do this. And in my own particular case, too much time went by before I said, you know, I've got to talk to somebody because all I'm doing is cases and all I'm doing is this and that. And I have aspirations to do other things. So ask questions. So I wanted to talk to Rob about this particular slide. So this is an experiment we did when Mass General Brigham consolidated. We took some data collection from people at the Brigham and data collection from people at the MGH. And of course, we did genotyping, right? Everybody does genotyping, except the lab where you work. So you have to send them out to Mayo or Invitae or someplace like that, right? Pay a little price. And then, of course, we had to worry about ancestry in the study, right? Oh my God, ancestry. Everything we know is from the UK Biobank, right? Except everybody who's born in the UK, of course, doesn't look like people who are born in South Asia or people in Japan or people in Mississippi, for example. So we did some quality control and we democratized this genome-wide association study by looking at various ancestral databases. And then, of course, when we couldn't find the information, what did we do? We imputed it. We made it up, right? Think about that, right? So there is this whole thing about imputation, right? So is that okay, right? When you don't know the data, you impute it and you have these sort of 10 different ways to try to make it as realistic as you think it is. And, you know, it's an interesting exercise and we do it all the time, but I do have a sense of uncertainty when it comes to the degree to which data are imputed. And then we do our favorite thing. We produce a Manhattan plot instead of a Brooklyn plot and wait till next year, so to speak. And then, of course, that's not enough. You do a meta-analysis. So let's pull in similar data from other cohorts and see whether or not we can replicate it, right, in an external independent data set. And then we get to this thing called post-GWAS analysis, where we're actually then trying to find out, does the rubber actually meet the road? So you find these SNPs and what are the protein derivatives of the SNPs and do they affect the outcome that you're trying to achieve? And that's a lot of talk, of course. And then you get these displays in which you can overlay genetic information with something else that looks like an 1980s stereo. And if you play this in real time, right, you get those things that go up and down, right? Red, that must be really a hot, this is what we're doing, of course. And if you're very successful, and I don't see anybody here for Peter, and then you develop the brain of an electrophysiologist. There it is. So that's how EP people think, and that's why they need to be segregated in the lab. God forbid, right? So you lose the gene to write a prescription. The general cardiologist does that for the electrophysiologist, right? Oh, does that happen here? Right, but then you gain the gene, right, to try to understand the three-dimensional space and electrophysiology of something as complicated as the sinus node or epicardial VT ablation. And thank God they do, right? But anyway, we're all in this together. So this is really my favorite quantitative mapping, quantitative trait mapping for various polymorphisms that may dictate phenotypic traits of any one individual. Now, this sort of reminds me, and I can tell you how old I am, but you remember the word bacteriophage, right? A little virus, and sort of you put it in. Looks like a bacteriophage, but make no mistake, right? There's methylation here, there's RNA signaling here, and then there's some sort of score that's supposed to be able to tell you when you look at that, the likelihood that any one particular polymorphism is associated with any one particular physiologic trait. And because that's really so hard to understand for the general cardiologist, we've put it in a different way. And this is systems biology. Okay, so you have to be Joe Lascalzo to deconstruct this and say, yes, here's the node. Why couldn't you see that? Of course you can't see that, right? But is it necessary for me as a general cardiologist who's sort of slugging it along, taking blood pressures and worrying about patients' compliance and talking to folks on the phone because they haven't taken their warfarin for 2 or 3 days? You think, I'm still doing this. Yeah, I'm still doing this, but I'm certainly not doing what's on this slide, right? However, right, the world is potentially going to pass us by unless we're at least cognizant of what this all means and how this all comes together. It's got to be true in some sense. We need to unravel it and make it useful to the clinician at the point of care in order to enable better outcomes for our patients. I think there's probably something to this, and lots of very smart people are going to help us try to unravel it. I'd like to know a little bit more about that when it comes to things like the genetic basis for aortopathies, when it comes to things for like somebody with arrhythmic mitral valve prolapse, and you think it's all related to a scar in some area of the heart. Turns out that they have multiple genes that predispose to ventricular tachycardia. Good stuff. And coming up more frequently, we have so many more ways of thinking about our patients than we did 40 years ago. So many more ways. Okay, and here's my friend. I brought this for Bobby. Mendelian randomization, where you have some sort of instrumental variable on the left, G, which it might be gene, for example, or a single nucleotide polymorphism, and then an exposure, like a protein, and then an outcome. And for me, this actually all started about 12 years ago when a certain paper came out about the association of lipoprotein A with aortic stenosis. I no idea exactly what this meant, nor did I know who George Davy Smith was, but as far as I can tell, he's everywhere, right? And posthumously, he may still be everywhere. Okay, so let's get down to some concrete examples of some of the things that I have been impressed with over the course of the last couple of years, and see what you think. Now, there are various stages in the life of a patient with valvular heart disease, right? They have it, you don't know it, you need to screen for it and detect it. Now, this could also apply to atrial fibrillation. How good we are screening for atrial fibrillation. How many of our patients with atrial fibrillation are symptomatic? How many are asymptomatic? This is a big deal. And of course, in the world of transcatheter therapeutics, there's this almost a sense of guilt that we're leaving so many patients behind who have severe valvular heart disease and they're not being treated in a timely fashion. Maybe that's true, but I'm sure that from your perspective here at the BI and perspectives at MGB, we can't possibly take care of any more patients with valvular heart disease. They're lined up outside the door. And mostly it's a discussion these days of advanced heart failure. You see Jen in the front row here. It's definitely true that we're at this interface that we were somewhat at in maybe 50 years ago with stenosis, but we're in it every day in patients with tricuspid and mitral. So let's screen, all right, and then what do? We refer and we assess. We refer perhaps to people who may have a better understanding of the natural history of the problem, and then we assess. Usually we just jump on them with multimodality imaging, occasionally an exercise test, and infrequently a hemodynamic assessment or something like that. And then we treat, and then of course there's medical treatment, and then there's some kind of intervention, which could be transcatheter or surgical. And then there is this thing called follow-up, which has received almost no attention over the course of the last 15 years in patients with valvular heart disease. So this is a picture of me as a cardiac fellow. And there's my fellowship program director, the late and great Dr. Peter Yurchak, who also was a Brigham trainee, before he started at the MGH many years ago, shared an office with Dr. DeSanctis. And of course, here is Lynette with the early generation stethoscope that, as you can see here, is about 210 years old. And it was one of the factors that led to its development, of course, was the reality that it became uncouth for male physicians to listen to female chests with their ears. And so a tube was created in order to amplify lung and heart sounds to allow the astute observer some understanding of what was going on. And of course, this is a landmark in the history of cardiology, just a couple hundred years old. Now, what are we doing today? Well, we're doing a lot of different things. And here's one particular example in which screening for valvular heart disease in a general practice, which can be done with, for example, a point of care ultrasound. But we still like the stethoscope. I still think it defines us as a specialty. Everybody's got a picture of cardiologists with a stethoscope around their neck. Just think if we got rid of it, right? We'd have to come up with like a new avatar. Like, all right. So you can amplify the heart sounds, listen in 3 different places, filter them, send them to your iPhone, and then through some software come up with this kind of screening mechanism by which you can ascertain whether the heart murmur could be pathologic based on its characteristics, its intensity, and its location, right? Think of that. Those are sort of the basic things you do at the bedside. How good are cardiologists are actually making that identification? Not good. Right? So that gets back to why we shouldn't be teaching people to do ultrasound as medical students. But if you can do this, as you see on the bottom right here, the performance of the smartphone application is really pretty top notch here. 90% precision, recall, 95% accuracy. It's an interesting observation, and it seems to me that perhaps we could use some technology like this if in distributed primary care practices and general cardiology practices, people were interested in this, and you could then make sure that the information is filtered appropriately and then received at some place where a output could be accomplished, such as referral to a valve disease enterprise. And here, of course, is something, I don't know if you guys are doing this and you have embedded it in your routine care, and that is artificial intelligence analyzed ECGs. Are you using this? They're using it now at the Mayo Clinic, apparently on a routine basis. And this is a Mayo Clinic study that suffers from the big drawback for most of these studies, lack of external validation, right? So however this performs internally, it almost always performs less well externally. But suffice it to say, they were able to achieve, as you can see from the table on towards the bottom right, that reasonable sensitivity and specificity with areas under the curve that exceeded 85% or so. And people have applied this to all types of valvular heart disease, mitral, tricuspid regurgitation, aortic stenosis, and aortic regurgitation. And we're getting better and better at analyzing data that are embedded in the ECG signal that the human brain and the human eye cannot actually ascertain. I think there's something to this, and I think that we probably are going to need to be comfortable as to the degree to which this is validated. I know that there's a group here at the BI that have applied this to hypertension and trying to predict incident hypertension from an ECG in a patient without prior diagnosis of hypertension and without LVH. That's pretty extraordinary. And they've done that here, and then they have validated it in, of course, the UK Biobank and other data sets. So this could actually, I think, begin to insert itself into routine practice with probably more training and a higher degree of validation. And then let's get back to this particular paper, which was published in 2013, showing an association between lipoprotein A and incident aortic stenosis and the need for aortic valve replacement surgery. So for those of you who are not aware of this particular paper, I'll show you the reference here as we go. But there were at least 4 or 5 different types of methodologies used by these investigators to try to convince the reader and themselves that there is a valid association between lipoprotein A and calcific aortic stenosis. And of course, people are headlong into phase 3 trials looking at newer agents to lower LPA, not only to reduce the risk of coronary heart disease events and stroke, but also to reduce the rate of progression of aortic stenosis. So this has been around for a while, but I thought that this was extraordinary in terms of how these investigators put it together. And for those of you who are interested to try to understand the several different types of methodologic analyses that were performed, it's a really useful, I think, exercise. If I were teaching at the clinical effectiveness course, there's not a chance in hell that's going to work or come to fruition. I would look at this particular paper as something that could influence how a clinician should think about this entire area. So there's Mendelian randomization here. There's instrumental variable analysis. There's the use of data sets across 3 different populations from MESA, for example, Cardia, et cetera. And then they went as far as to track the patients longer term and to actually show, yeah, it's great that it's associated with calcification of the aortic valve, but guess what? It also associates with the risk of the need for aortic valve replacement surgery for severe aortic stenosis. So kind of a cool thing. And I think we're in a similar spot, but a much more nascent spot with a degenerative mitral valve disease. The figure here on the top left is a cartoon from our colleague Bob Levine, who's been studying this particular problem for almost 50 years now. Bob has had an interest in mitral valve prolapse that is 5 decades in the making. And then a patient with Barlow's syndrome. And this is David Milan's work, I think, and Patrick Eleanor, who found several genome-wide associations significant of SNPs that associate with mitral valve prolapse. And you can see that these fit within the family of cardiomyopathies and TGF-beta signaling. Kind of makes sense. And how many patients have you seen in which there's a familial history of mitral valve prolapse? Or they have mitral valve prolapse and bilateral inguinal hernias, or they have poor tissue healing and they bruise easily, or some combination of that. So there's a whole bunch of folks with non-syndromic degenerative mitral valve prolapse that have more than just mitral valve disease. And I think that this is a very exciting field. It's been a little bit more difficult to study. So now that we've screened and detected this problem with genotyping, for example, what about the use of diagnostics? These are certainly not embedded into routine clinical care. I really like this slide because everything is smart. Right? You can remember this like you falling asleep, right? You got smart socks, smart watches, right? Smart glasses. I don't have any of these things. I don't have a single one. But just think, we've been talking about this for a long time, haven't we? And people like Verily and Google, they've been working at this for a long time. Facebook, I think, right? Meta, everybody's working on this, but it seems so far away. I don't know whether it's because there's too much noise in the system, right? Or just think about following our patients with heart failure and having all of this information. What really makes a difference for a heart failure cardiologist? Is it the MEMS device in the pulmonary artery? Or is it the fact that the nurse navigator is calling the patient every day, making sure that they are weighed and they're taking their pills and all things like that? But gosh, it's really incredible, I think, to think of a future that would allow a patient to bring physiologic information with him or her to the office. And I hope that this happens during my lifetime, as much as I hope that we come up with a drug to prevent the progression of aortic stenosis. But just imagine that your patient who tells you, well, I'm really tired. It's really hard for me to go up a flight of stairs. What are you going to do with that information, right? Your aortic stenosis must be symptomatic. Maybe, right? Most of the time you're deconditioned, you don't use the stairs, you don't exercise, you have issues with your knees, you have issues with your body size, you have issues with other medical problems. But if we had physiologic information, could we be more precise at predicting a change in the natural history of any one particular disease that we see? Of course, POCUS, I can't forget to use that. And imaging, of course, is everything. So here's some examples of patients with aortic stenosis, and I'm sure this is not only familiar to you, but recently reviewed with Bob, including echocardiography, CT calcification, and CMR, which is really a very interesting tool to study patients with pressure overload, whether they have aortic stenosis or hypertrophic cardiomyopathy, or even systemic hypertension for that matter. And fibrosis is the enemy, isn't it? Replacement fibrosis doesn't go away, whether you replace the valve or not. It only gets worse. And they're really smart people, and this is really old data now. Here we are in 2025. Parthos and Gupta, who's in New Jersey now, put this together some time ago, where he established this notion of phenogrouping patients on the basis of information that's collected from 3 different imaging modalities: echocardiography, CMR, and CT, and being able to predict who among a population of patients with aortic stenosis had high severity aortic stenosis, which associates with higher risk of the development of indications for the need for aortic valve replacement over a shorter period of time. And I think his group was really one of the first to help the clinician try to integrate this information and send a signal that you can do this if you pay attention and you know how to integrate data from a set like this. Now, that's all very fine and good, but we need to prospectively validate something like this, because it's very expensive in the process of taking care of patients, isn't it? When most of the time a good echo and a good history will probably suffice. How much better will additional information about extracellular volume index be, for example, or the precise Agatston score? So one of my recent interests, like many other people, is that of how to predict sudden cardiac death in patients with mitral valve prolapse. Here we're talking about a small percentage of people in the universe of those with primary or degenerative mitral valve disease. And this has been postulated and sort of poked at for at least 2 decades. And occasionally, though, you do see patients, don't you, with less than severe mitral regurgitation, lots of ambient ventricular ectopy. They haven't passed out yet. They have not had syncope. Right? Is syncopize a verb? This is just a little break in the action. Is syncope? Isn't that your favorite? So then he stood up and syncopized. So we have to ask whether syncopize is a verb. And the answer is no, right? Or the other one was, it was decided. Right? So that's a good one, isn't it? Right? So who decided? all right? And what was decided, and et cetera. So we have to be really careful, I think, in terms of our vernacular, don't we? So I decided, right? And I was wrong. And so then I had to turn left or something of that sort. But your patients have syncope, but they don't syncope. Anyway, all right. So these are an interesting group of people because the question that they pose, and certainly, we might find these in some people, but the question they pose is whether or not to correct the mechanical lesion in order to reduce the risk of sudden death. You never think in those terms, right? So if the biomechanical lesion of mitral prolapse, right, with tensing of the leaflets, pulling them into the left atrium, causes that repeated injury to the papillary muscle, and that creates injury and fibrosis, and that becomes possibly a nidus by which ventricular arrhythmias occur. Should we be replacing patients with moderate, or should we be operating on patients with moderate MR much earlier in their natural history if they have markers of high-grade ventricular ectopy? So there's lots of ways by which this can actually be studied, and Dave Adams' group at Mount Sinai in New York have certainly been front and center with this. And I love this picture from Circulation several years ago. It's probably the best correlation I've seen between somebody with late gadolinium enhancement on an MR and the fibrosis that occurs here in the same region. You see the mitral leaflet on the left, obviously a postmortem specimen in somebody who had gone through this kind of evaluation. But these are the sorts of things that we never thought about before that are not only intellectually interesting, but if we can become more precise, I think, we can actually change the natural history of disease, even in a few patients. And that's okay. Now, you guys have to know everything about CHIP because, of course, the president of the DFCI is going to be your partner in a short period of time. So certainly Ben Ebert has contributed enormously to this field, and this is not a slide from Peter Libby. That's kind of an inside joke, okay? All right. So shouldn't we know something about CHIP? We know things about immune checkpoint inhibitors, don't we? And if you see patients with cancer who have cardiology complications, CAR T cell therapy, immune checkpoint inhibitors. And now, what about CHIP? How should the cardiologist think about CHIP? And whether or not some knowledge of the biology by which these sort of somatic mutations escape during late age could predispose to atherosclerosis, for example, maybe even aortic stenosis, given the crosstalk at the level of the aortic valve between atherosclerotic risk factors and the development of valvular endothelial and interstitial cell pathology. So I think that this is also a very interesting area about which we should be familiar. And then the molecular targets that come with medical therapy that are directed against some of these things that we're starting to learn about. It's okay for us as general cardiologists to be remotely familiar with this thing called lipoprotein A. It's like the bad penny that won't go away. And its activity mediated through NF-kappa beta. Who knew, right? IL-6, Paul Ritker, tocilizumab, COVID, all of this is starting to come together, isn't it? Autotaxin. And then these fancy molecules that we have to reduce lipoprotein A levels and trying to determine whether or not by reducing it, we actually improve outcomes. Antisense oligonucleotides or small interfering RNAs, things not even in our vernacular. And of course, Mark Sabatine is clever enough to try to use an agent that's already been approved for use in the United States for people with hyperlipidemia, PCSK9 inhibitors. And on the upper right here is a paper from Brian Bergmark and Mark Sabatine looking at a landmark analysis of aortic valve events on the y-axis versus time on the x-axis and showing a reduction in events among patients who were treated with evolocumab in the Fourier study. This is not new information, but it's there. And I think it's interesting. I'm sure your patients are asking you to go on PCSK9 inhibitors because their LPA levels are elevated, right? And you say, oh my God, how am I going to be able to get this approved, right? Okay. Now, the other thing that I think is on the horizon, and maybe, Bobby and Rob and Peter, you might disagree, is can we create avatars of our patients and then probe and test them with various perturbations and try to predict what might happen if they were referred for surgery, if they had an ablation for atrial fibrillation or ventricular tachycardia. Now, I didn't know anything about the digital twin. It sort of reminded me of doing research with an N of 1, and that was all the rage maybe 20 years ago or so. But when you think about it, if you can construct these avatars using computational means by which to do so, it's absolutely science fiction to think about whether or not you could use this as a model by which you could tell patients, well, guess what? If we did this to you, you have a 10% risk of X and a 48% risk of Y. We're certainly not there, but perhaps the underpinnings of the technology by which this could be accomplished is already present. So it turns out that in this NHLBI primary trial, for which I'm one of 3 national co-PIs, we're trying to predict the response to mitral tear versus surgical mitral valve repair in patients with degenerative MR. So the trial is actually designed to prove that surgery is superior to the clip for the treatment of patients with mitral regurgitation from prolapse or flail. Boy, if the surgeons don't like this trial, they're not going to like anything, I have to tell you. So this is not a non-inferiority trial, and rest assured, we're not going to penalize surgeons for causing more bleeding that occurred in the Everest trial 15 years ago. But it's kind of I think, a good trial in response to all of the patients who are flocking to our structural valve disease centers, asking for minimally invasive or the minimalist invasive treatment for the problem that they have, even if the information about the long-term effects of that information have yet to roost. So, Bobby, I brought this slide for you because on the bottom left are some Wynn-Kessel equations that relate flow to resistance in the circulation. And so people at the University of Michigan actually are using this information with derived from contrast-enhanced cardiac magnetic resonance imaging to construct in silico models of the heart, and then to test it in silico following clip repair with a little bit of MR left over versus the surgical approach with less than a little bit of MR left over, and whether or not that would impact left ventricular, left atrial remodeling over what period of time, and whether that would impact a predisposition to atrial fibrillation or ventricular tachycardia. This is all cool stuff. And we're also, I think, including in this a genetic and proteomic arm that Patrick Eleanor is helping with, in which patients with degenerative MR taken to the operating room are having papillary muscle biopsies performed, or biopsies performed in the region of myocardial fibrosis in patients with mitral valve prolapse. So I think that it will be interesting to see how this turns out. It's probably, I think, between now and 3 to 5 years down the road. So here's an example of how it might work. And this is from Hugh Calkins, whom you might know, or you might not know. Hugh is one of the leading experts in atrial fibrillation ablation. He's been at Hopkins for a long period of time. He trained at the MGH and then went to the University of Michigan. Super guy. So what his group did was on the top, you can see patients who have ARVC. Okay? And you see the big right ventricle there. And then you take them to the cath lab and you try to map their VT circuit. And you're informed on the basis of the size of the ventricle, right, as well as the distribution of the fibrosis in the context of ARVC, where it is that the circuit might reside. So on the bottom left, what they did with some of their genetic colleagues is they took 2 different cell types that have been associated with ARVC, depending upon the genetic mutation. So there's an elusive mutation, according to this, and then the plakophilin mutation. And then they put these cells through various cells mediated or cells that contain these particular mutations. They put them through a series of experiments and tried to predict on the basis of the cellular genotype what the circuit would look like in the ventricle, and then matched the two and found it that they actually overlapped. So here's an example of being able to create an in vitro avatar and then try to predict what the outcome might be with respect to the target that you are attempting to identify. So let's not forget, in terms of our interventions, that there are better valves to be made, and it's okay for us to have a little bit of knowledge about tissue engineering and heart valve construction. We've been putting pigs and we've been putting horses and we've been putting cows in people for a long period of time. And of course, we've been putting metal valves in people, and nobody likes what we're putting in. And the question is, of course, can you build a better valve? And can you build a valve from the patient, or can you build a valve in an agnostic way, as shown on the bottom, where you basically take a cell-free scaffold and then you put the patient's leukocytes and platelets in it, and over time there are these processes of inflammation and tissue remodeling, and the next thing you know, you can get some collagen elastin deposition and something that looks like an autograft used at the time of the Ross procedure. So these are the stages of the patient journey with valvular heart disease that I try to attach to some of these larger concepts that I think are in front of us all the time and require us to be a little bit on our toes. And of course, the issue about follow-up is a big question because so little of our attention has been focused on this particular aspect of patient care. For example, there are studies that imply that the use of RAS inhibitors are associated with improved survival after TAVR. No studies have been done on the treatment of patients with heart failure, preserved ejection fraction, and aortic stenosis, which must be an overlying phenotype, right? So I think the field is ripe for using those magical drugs, GIP and GLP-1 receptor analogs. And obviously, this gets back to our quest to deliver on the promise of personalized medicine. I think we're a long way from that. Like everything else and the things that I showed you with regard to the wearables, we've been talking about this for a long time. It's really hard to do this, isn't it? Everybody's a little different, but it's true. You see one case of aortic dissection, you see one case of aortic dissection. There's a personalized substrate for you if there ever was one. But we need to validate, we need to scale. I don't know if that's the right word. And then of course to be able to prove value, which means that quality is up and cost is down. Everything is more costly today. It could be a game that we can't really win at. So I'm going to take a page from one of my other mentors, Dr. Fuster, with whom I interacted at the NIH for the brief tenure that he enjoyed there, if that's the right word. So these are 5 attributes for the cardiologist. And to those of you who love Valentin, like I do, of course, he has slides that say 12 of this, 5 of these, 6 of these. Okay, but I don't have the colors, the yellow, the oranges, and the reds. So these are 5 attributes for the cardiologist, especially for the fellows in the audience and the early career individuals. You got to focus. People have to really recognize that you can walk the walk and talk the talk. So you're at that point in the time-space continuum where the funnel is narrowing, and you're going to be an expert in what it is that you're doing. And then as your career unfolds, you can wiggle your way around to other things. But you do need to integrate broadly, don't you? I think somebody like Rob, who's an incredible role model for being inquisitive and energetic and bringing things and people together, is a wonderful example of that. Remain inquisitive, otherwise it's time to hang them up, of course. Know your limits. Call somebody who knows cardio-oncology when you're dealing with a patient who might have immune checkpoint inhibitor myocarditis and you don't know the dose of methylprednisolone. Don't stop learning. Take advantage of the fact that before all of this started, you went to wonderful universities and you had this great thing called a liberal education. Maybe you were a science major. Maybe you studied philosophy. Don't forget that. Right. Don't forget that and explore that, because I think it all comes back to help you in conversations with patients, in conversations with hospital administrators, policymakers, you name it, elected officials. We're not going to go there. And then, of course, a little bit of resilience helps, doesn't it? And there are many, many times in which things are harder than you think they should be, but that's, I think, part of the process that we all go through. I had a wonderful career at Mass General and made my way over to the Brigham and wandered in the desert for 2 years while people accusing me of generalizing the Brigham. But what a great opportunity it was. What a great opportunity you all have being here at the Beth Israel. And I really do appreciate the opportunity to share this time with you. Thank you very much.
Thank you so much for that incredible talk. We have a few minutes for questions. Dr. Buxton.
Oh, hell.
The emphasis that you made over and over again on imaging is important, but in so many areas of cardiology, especially arrhythmias, that I know a little bit about, imaging is nothing without an estimate and measure of function. And people think that you do an MRI and you see some delayed enhancement, and that means you're going to die if you don't have a defibrillator. And but it's so much an emphasis guiding care just on an image, on anatomy, without taking into account function it's disturbing. And it's a big limitation because it's much more difficult in many areas to assess function than anatomy.
Well, that's a great point. I don't know if everybody heard that through the Zoom, but Dr. Buxton was emphasizing the relationship between imaging findings and function to put things into appropriate perspective. Thank you for doing that. I can share a case with you recently. I was sort of referring to it before, but I inherited the admitting service for the New Year's holiday, right? So go down the list, start with O, you're on for New Year's. Okay. And I met this young man, he's a lot younger than me, maybe 63, young man. And he had mitral valve prolapse and came into the hospital with syncope and ventricular tachycardia, and had been seen by a lot of folks by that time, had an abnormality on his cardiac MR scan, moderate mitral regurgitation, and we're going to go in there and ablate it. That was it. That was the morning I had met the patient. He was scheduled for an ablation an hour later. So 2 hours later, I get this call from another one of my arrhythmia colleagues and saying, well, did you look at the admission ECG? I said, well, I'm sorry, I didn't admit him. He just came in, et cetera, blah, blah, blah. Well, as it turns out, everybody was so focused on this area of late gadolinium enhancement, they missed the reality that his VT was not even close anatomically to where this abnormality was. And if you looked at the 12-lead ECG, you might be able to discern that, for example. And it turns out that he had a tricuspid valve annular VT. And it also turns out that after he'd been cardioverted from his VT, he had an epsilon wave on his 12-lead ECG. So like, how does a general cardiologist fit into that kind of a discussion when the train has already left the station and you anchor on all of these things, right? So anchoring is not a good thing. And there many, many decades ago, there was a very famous cardiologist here at the Beth Israel Deaconess Medical Center. His name was Robert Arnold Johnson. Anybody remember Bob? So Dr. Johnson was the editor-in-chief of the MGH textbook of cardiology, for which there were 2 editions. They're collecting dust in the basement of the Countway Library. But Bob was an extraordinary clinician who actually left clinical medicine at one point to write verse, not poetry, verse. Took himself to Tuscany in order to do that and just sort of went off the grid for a few years. So Bob had some great statements when we were first-year fellows. We present him cases. He was so meticulous and so bright. And then somebody would say something on the order of, well, I assumed that the people who made this observation had integrated the, blah, blah, blah. And he looked at us as trainees and said, assumption is the mother of F up. And I'll never forget it. So be careful about what it is you assume. Be careful of your anchoring for sure, which goes on a lot in places like this where there's a lot of busyness. And the next thing you know, you're sort of sucked into this vortex that was initiated in the emergency room on the basis of inexact information or imprecise. Anyway, that's an editorial comment. Any other questions? Alec.
Describe all the amazing tools and toys that we have.
Yeah, you're going to figure out how to use them.
The ivory tower.
Yeah.
How does this, do you worry about the polarization, if you will, between the academic centers and the community? How does the community over all this stuff? Are they just going to refer here whenever it gets tough?
Well, I think that there are some positive reasons for which referral should occur, but I mean, let's face it. We need to help them in their own practice, in their own locale. And so part of our job is to make this simple enough that it can be embedded in routine practice. It doesn't have to be a secret. So we're on the early stage of things, but it shouldn't be just for us. I think we need to test it and we need to get it out there. We need to disperse it rationally, much like new technology for interventional cardiology, right? We've been talking about that since Rick Kuntz put, what was it, CPAC or something like that together? Was that the name of it? CDAC, right? And we wanted to rationally disperse things. Well, let's do this as well. Things are really expensive, and we won't talk about all the other I think stressors in the system that make it almost unattainable, but we can enjoy this sort of 60 minutes of fantasizing. Rob.
I love your talk. The talk, you kind of ask yourself, is that adding value on top of things general cardiologists already know? Yeah. So my question is, as an editor at JAMA Cardiology, or a journal that I think is, I'm not trying to, it's really doing very well. Do you guys have a lot of those discussions where you say, okay, they use this fancy schmancy, whatever it is, predictor, how much does that add on top of just what their EGFR was, what their hemoglobin A1C?
Yeah.
What are in a real world that you guys adjudicate people?
Yeah, I'd say it's about 10%. So it seems to, really smart people like the other editors, Sabatine and Anne-Marie Navarre and people like that we have to hold authors and investigators to certain standards about trying to prove the degree to which it does make those improvements. You're absolutely right. And it's not so much the NRI or the IDI that comes because these decimal points, sort of, is this really a significant difference? And then is this a breakthrough? And a lot of what we see, I think, and Rishi can comment on this as well, is that these are really, really minor calibrations, so to speak, of basic observations. So the one thing that comes to mind, Rob, is that somebody came up with a prediction score for heart failure on the basis of AI analyzed ECGs, and compared the AI ECG to currently available clinical risk scores for heart failure, PREVENT or PCP heart failure or something like that. And it looked really good. And then somebody asked, well, how does it compare against the base variables in the risk score? No delta. So it certainly throws a little bit of cold water on a lot of the things that are published and that we publish, right? You don't want to be left behind, for sure, on the one hand, and it's okay. I think we're working on it, but your question, I think, brings us back to reality.
This is one of my most favorite backgrounds I've heard, so thank you for sharing your insights. I think when you showed your tips for the early career cardiologists and fellows, everyone put their phones out, showed us how much they thought of it. But I was interested, and this is slightly philosophical, but I guess what do you think is the greatest challenge for fellows and early career cardiologists at the moment? Is there any difference compared to when you were trained?
Sure. So what is the greatest challenge, I think, for cardiologists in training? It's being able to detect the noise and discard it so that you can remain focused on the message. I think that the amount of information that comes to you is probably 1 trillion times more and 1 trillion times faster than was the case 45 years ago when I started as a fellow. I mean, we thought we thought aortic dilation in the context of aortic stenosis was because of a hemodynamic insult. We thought people got aortic stenosis because the valve sucked up calcium. Really? Right? And so, but now you have all of these things and you have new tools. And so it's more difficult. You spend less time on the blocking and tackling that we did when we were fellows. You spend less time analyzing ECGs. You don't look at chest x-rays. No one supervises your physical examination. And those are things that we still rely on, believe it or not. Depending upon your stage of training, you go back to what makes you feel confident that you can get your hands around the information. And it's much easier when you have that same kind of methodology, but now you've got all of this stuff talking to you. What's the focus? And I think that comes with experience. I think it comes with making mistakes. I also think it comes with somebody being able to help you, saying, well, that's our job as faculty. Say, well, here's the question that this patient is asking. All the other stuff is good, but this is what we need to answer. How do you complete the transaction?
Thank you so much, Dr.
Thanks a lot.